Herkese hoş geldiniz.
I would like to welcome each and every one of you, and I would like to thank the organizing committee for this organization and everyone who exerted effort in the organization. In summary, I will be talking about treatment of tic disorders, and I will be talking about recent trends in terms of treatment and treatment tendencies in the new guidelines. This is the content of my presentation, description of tic, DSM-5 criteria for this tic orders, because there are some changes in DSM-5. Pathogenesis, prevalence, prognosis, characteristics, treatment indications, behavioral treatment, pharmacological treatment, and then I will be talking about all of them in summary. What's a tic? A tic is a sudden, rapid, recurrent, and non-rhythmic motor movement or vocalization. In DSM-4, they are defined as stereotypical. However, in DSM-5, we do not see such a definition anymore. Right now, tic disorders are under motor disorders, under neurodevelopmental disorders. It covers similar features. The names are a bit different. For example, instead of chronic, we use persistent. Instead of transient, provisional is used. It is not known whether it will become chronic or not. This provisional word is used, or unspecified tic disorders are defined. When we talk about Tourette disorder, if you just remember it very briefly, a motor tic or one or more vocal tics are present for a period of 1 year or more since the very onset. And they will start before the age of 18, and it's not going to be dependent on any substance or any other medical condition. The tics may increase or decrease over time. And there is a difference from DSM-4 here. For about 3 months, there should be no period without a tic. That was the specification DSM-4, but right now it is no longer present in DSM-5, and there is no such statement. So just 1 period from the onset of tic is enough, according to DSM-5. Motor vocal tics are a bit different, or motor and vocal tics, we have to last for more than a year, but they don't have to be together. This is the provisional tic disorder. It says tics which last less than a month. Tourette and chronic vocal motor tic disorders are defined as such. When we look at the pathogenesis, dysregulation of dopaminergic neurotransmission in the corticostriato-thalamocortical circuits, as mentioned by the previous speakers. Please forgive me. Your presentation is very interesting. Let's pass on to the treatment, and then we can allocate some time for questions and answers, because there is a lot of interest in the topic you're discussing, and so that we can allocate more time for questions and discussion, because we can share the experience this way. It's a very short presentation already, and these are the prevalence rates. Typically, age of onset is between the ages of 4 and 8, mostly 7. Peak is between 10 to 12 years old, decreasing by adolescents, and there is good prognosis for tic. And during adulthood, 1/3 of the cases have no tics anymore, and 1/3 have mild tics, and 1/3 have severe tics. These are the characteristics of tics. Increasing and decreasing in terms of severity is like a feature. On certain periods it increases, and certain periods it decreases. So there we talk about the sensory phenomena as association and exacerbated by stress and related by distraction from the trunk to the extremity. The route is followed. It starts with the face, then it passes through the extremities. It starts with simple, then complex tics, and phonic tics usually appear after the onset of the motor tics. Very roughly speaking, you see the reasons for attenuation, exacerbation, stress, anxiety, worry, frustration causes exacerbation, but when there is concentration and relaxing activities, it may attenuate. So ticks, voluntary or involuntary, this question is very important. It is important for treatment purposes as well because behavioral therapists are using this answer. It is not completely involuntary, but we cannot talk about its voluntary nature either. It's called semi-voluntary. In many trials and in many studies, the people with tics are questioned as to, for example, look at the very bottom. Here it says that 135 individuals were asked in Lekman's study, and 92% said that their tics were either fully or partially voluntary response to their premonitory urges. So it is a voluntary action as a result of involuntary urge or impulse. So when should we treat them? Because simple tics do not require treatment. If they cause social problems for children, for example, and if it causes emotional problems for children, and if the tics cause functional interference with the lives of the children, like the academic achievement or sports activities, if these are a hindrance for the children, are causing subjective discomfort like pain or injury, because with some neck tics there may be some injuries in the spine. Therefore, in these cases we talk and we need treatment. So what are the important points for treatment? After psychoeducation and reassurance, many patients do well with a watch and wait strategy. Usually the children and adolescents can get away with it. They do not encounter many problems. Another important point is that the effect that pharmacological treatment of TS has on the natural long-term course, and we still lack evidence in that respect. There may be ups and downs in terms of the phases. All pharmacological treatment options are therefore mere symptomatic treatment that alleviate but do not cure the tics. It is essential to detect coexisting conditions, comorbidities, and at this point we have to understand the tics and the comorbidities and their influence on the life quality and functionality of the children. So these comorbidities should be examined very well. And when we are establishing the treatment hierarchy, we should begin with the most impairing condition. That's how the treatment plan should be made, because in many circumstances the comorbid condition is more influential on the functions rather than the tics. This is the psychoeducation definition. For example, what should be the prognosis, what are the risks, and what are the co-occurring conditions. About all of these matters, the child and the families are informed. And in the classroom, for the classroom facilities, you may also have to inform the teacher as well. For example, when the child has to leave the classroom, he or she will be able to leave the classroom, and the teacher should be informed about this need. This is the behavioral treatment. The ones with the stars have been proven in order to be effective. So the ones which are listed at the bottom, like habit reversing, the ones which are listed at the very bottom can be added to habit reversing, like mass practice, relaxation training, self-monitoring, function-based procedures. This is the environmental factors which influence the tics of the children and the interventions with the environment of the child, and cognitive behavioral therapy. The mass practice or negative practice was considered to be effective in the past. However, subsequent studies proved that these are not very effective. So you increase the child just is forced a little bit to do these tics very intensively, and they think that it's going to come to an end after a while, but it's not very effective at the moment. Habit reversal treatment, there are two main components. So you have to increase the awareness of the child about the tics, and this is the first component. The second component is that competing response training. There are some examples in this table. For example, the tic is shoulder shrugging. For example, instead of that, keep arms at the side while pushing the elbow towards hip. These are receiving less attention, and it is like a substitution for the tic. A meta-analysis study worked on 12 other studies, and in these 12 studies there are 90 participants, and 94% of them experienced tick reductions, and they showed that the effects are long-term effects. Wilhelm and his colleagues saw continuous benefits in 86% at 3 months follow-up and 80% at 6 months of follow-up. In a study, when they were called by telephone 2 years later, 52% of the patients still experienced 75 to 100% control over their tics. Again, in the Woods study, in Woods trial, HR is effective in reducing long-term secondary psychiatric symptoms as well and improved social functioning. There's good evidence regarding that. And other behavior treatment which has positive impacts is exposure response prevention, based on the conditioning. And we talk about a disturbing feeling first, and then it is followed by a tic. And as the person repeats this tic, it becomes reinforced. And we have to break the cycle. And that's the logic behind this mode of treatment. And it is like exposing the person to this feeling more and trying to increase the tolerance. And this way, the numbers of the tics is decreasing over time. This is from the European guideline. It's an algorithm of 2011. There are mild symptoms, and in that case, psychoeducation and monitoring can be enough. For moderate and severe symptoms, psychosocial, if there is psychosocial impairment, the preference of the child and parents is to get treatment, and if there is availability for intervention, there can be 3 choices, like medication, habit reversal, or exposure and response prevention. So let's say that we had 10 sessions of this. If there is response, it is sufficient. If there is partial response, then the treatment should continue. But if there is no response, then you should go on with pharmacological treatment or with exposure treatment. For exposure and prevention, response prevention treatment, if we have positive response, we stop the sessions. If it is partial, we continue. And if there is no benefits, we start with another behavioral treatment mode, or we can continue with pharmacology. From the pharmacological perspective, what do we do? Because until now I talked about behavioral treatments. It is very difficult to establish guidelines for pharmacological treatment. The reason is that when we look at this axis, we see tic severity and time. And this curve is showing us that the tic is decreasing. This is the natural course of tics, because during certain periods they're increasing and in certain periods they're decreasing. So in this period, if any medication is given, even though there is no effect, because of the natural course of the tics, even if it is going to have effect, because of the decreasing nature, natural nature of the tics, it may be seen as effective. However, if a medication which is given during this period, because of the natural course of the tic, if it is going to increase after a while, even if the medication is effective, it is going to seem like ineffective. Therefore, establishing algorithms and establishing guidelines are very challenging. Typically, haloperidol and pimozid are used most frequently, and haloperidol gets the FDA approval. Fluphenazine is also studied. About pimozide, 6 randomized controlled trials were carried out. In 2 of them, haloperidol and placebo were covered together. In 1 trial, pimozide and placebo, and in 2 trials, risperidone was compared. In 1 trial, haloperidol was compared. In summary, we see that pimozide was more effective than placebo. It was slightly less effective than haloperidol, but showed fewer adverse reactions. And when we compare it with risperidone, we do not see a very significant difference between in terms of reduction and in terms of management. When we look at the benzamides, they are selected D2 dopamine receptor antagonists, and they are a bit different than antipsychotics, because in contrast to the typical antipsychotics, they have low antipsychotic action. These have been used since 1970s. There are studies and trials about them, but they're not sufficient, and they're not enough in number. About typewrite, there is a trial on 17 children. It's a randomized, controlled, and double-blind study, and a significant reduction of tics was observed. But it's an old trial. When we look at Soprite, a very high number of children were included. It's an open-label study of 6 weeks, and the average age is 8 years. And the result is improved motor and as well as vocal tics reduction was ensured. Of course, it has some adverse reactions. What about atypical antipsychotics? Of both pimozide and haloperidol are very effective in terms of treating tics. However, because of their adverse effects, especially with regard to extrapyramidal effects, they are not the most preferred ones. Risperidone is mostly studied by double-blind studies. Risperidone also appears to be effective in treating aggressive behavior in patients with tic disorders like anger tantrums and some other disorders. When it is compared with clonidine, in a study of double-blind, 8 weeks, it's a double-blind study, a randomized one, and 21 subjects with TS between the ages of 17 and 7 were included, and risperidone, in terms of its effectiveness on tic, is equal to clonidine. However, in terms of tics plus OECD symptoms, risperidone is superior to clonidine. The studies on olanzapine are usually open-label studies, and there are several case reports on them. In a study of 52 weeks, it's a double-blind crossover study, and pimozide and olanzapine were compared, and both dosages of olanzapine were superior to pimozide. And thiopine is found to be effective. These are open-label studies, and there are many adverse effects, and they are usually given 200 milligrams a day. However, it has some adverse effects like sedation and other metabolic effects like weight gain. About ziprasidone, there are randomized controlled studies. It is well tolerated and it is effective. And no EPS or no weight gain has been observed, and there is no QTA prolongation. Aripiprazole, on the other hand, as you know, it acts as a D2 receptor antagonist under hyperdopaminergic conditions. It is usually seen as an antagonist, and it is seen as an agonist in the state of low dopaminergic neurotransmission. The most important shortcoming is that there are not enough studies of randomized and double-blind and controlled studies, placebo-controlled studies. These are still lacking. Case reporting and open-label studies prove that it is very effective, especially with regard to the resistance to treatment by other drugs. In 2013, a new study was carried out. It's an open-label study of 81 children, and it lasted for 14 weeks. I'm sorry. All of the tic scores have decreased, and This is a scale which is very frequently used in many studies and trials. It shows the distribution of the severity, and it also shows how the functionality has been affected. However, about aripiprazole, we do not see very good metabolic effects as we desire, because in many studies there is a proof of increased weight gain. A study was carried out of 8 weeks on 72 children between the ages of 6 and 18. It's an open-label study. A very significant reduction was ensured in terms of tick, and CBCL was used. A significant reduction of behavior symptom was ensured. And noradrenergic agents, clonidine and guanfacine, and you may not get away with the questions. I mean, you did not do the same thing with Pınar Hanım. You will get questions anyway, even if you just prolong the presentation. Clonidine is used more in America than Europe. Please finish. Please finish. Nihat Bey, with your permission, the lady can finish the presentation, then we can entertain some questions. Clonidine and guanfacine were studied by randomized and placebo-controlled studies. There are contradictions between the studies. Some found it effective and some did not find it effective. And this is a new study from 2008. And the number of participants is very high. 326 were included in group 1 with clonidine, and 111 included in the placebo group. And in the clonidine group, the response rate is very high. What are we using as alternative agents? Tetrabenazine, nicotine, tetrahydrocannabidiol, botulinum toxin injections, clonazepam, baclofen, and there is a study with omega-3 which was published in Pediatrics of 2012. In the number of ticks, there is no reduction. However, in terms of the functionality of the child, the scores are good. And as a result of this, as a placebo, olive oil capsules were given, and maybe because the olive oil can have some good results as well, because the results were still high in both groups. Botulinum toxin can be used for local ticks. Tetrahydrocannabinol and nicotine are not going to be used with adolescents, but rather for adults. I don't know if it is readable, however, very shortly I would like to draw your attention to a single point. These are the level of evidence. A, C, B, C. A means at least 2 controlled randomized study. C is 1 study, and B is case reportings and open label. We can see that clonidine, guanfacine, and haloperidol, all of them are in group A. This is an important slide as well. The experts in Europe were sent some questionnaires, and they asked if you think that there is no contraindication or comorbidity, what would be your first choice, and what would be the second choice? And 22 responses out of 60 questionnaires, and they rated each first choice agent with 4 points, and a second choice agent with 3 points, and a third choice agent with 2 points. So the risperidone was mostly preferred, then clonidine, aripiprazole, and pomazide, and this is the list of preference from the clinical perspective. this is the comorbidity slide. We mostly see hyperactivity and OCD as comorbidity with this disease. When it is accompanied by hyperactivity, it is of course higher in terms of psychopathological and social and academic impairments. Well-designed control clinical trials have not indicated deterioration of tics in persons treated with stimulants, but of course it may prevent having higher doses in the treatment algorithm. If it is accompanied with OCD, tics are more likely to persist into adulthood, and in terms of CBT, there is no significant difference between the two groups. And when TS and OCD are together, they are less responsive to SSRI and more responsive to SSRI and antipsychotics. In summary, in any case, psychoeducation should be the first step in the treatment, and most studied ones are risperidone, haloperidone, pomozide, and promising drug is aripiprazole, but we lack evidence and study in that respect. When it is accompanied with a hyperactivity, clonidine is the preference, and atomazine as well. And when it is accompanied with OCD, SSRI, and antipsychotic agents should be used, and the most frequently studied one is risperidone. And if you look at this table, it is also summarizing the algorithm, psychoeducation. If the tics are present and if there is no indication for treatment, only monitoring will be done. If there is indication for treatment and if there are comorbidities, first of all, the comorbid disorder should be treated. And if there is treatment of tics and if there is availability, behavioral treatment should be provided. And if it still continues, despite all these treatments, it should be combined with pharmacotherapy. I don't know if you can read it from here, but if there is availability, behavioral treatment should be provided, but if there is no availability, pharmacotherapy should be the first choice. But if everything is going well, monitorization should be continuing, and if the other ones are not sufficient, then comorbidities should be also treated and alternative agents can be used. This is all about my